Sige, so ang topic natin for this morning will be about HIV in association with sexually transmitted infections, tsaka yung pre-exposure, tsaka post-exposure prophylaxis. But before I proceed, they call me Doc Des. Tapos ayan, dali lang ah. Yeah. So, disclaimers, the opinions that I express during my lecture is from myself alone and does not necessarily represent the institutions that I am affiliated with. Tapos, we'll talk about STIs, PreP, and PEP. And the objectives of my presentation, tatlo lang naman, to present some local data on the different STIs and to discuss the syndromic approach to the management of STIs, including how we diagnose and treat and prevent them. And I'd also like to provide everyone with an overview kung ano ba yung benefit and current use ng antiretrovirals for the pre-exposure prophylaxis tsaka post-exposure prophylaxis against HIV. So, ang concept kasi natin sa ARV, sa antiretrovirals, is just for the treatment, di ba? But we can actually use ARVs for the prevention of HIV by using it as pre-exposure prophylaxis or as post-exposure prophylaxis. Okay, so these are additional disclosures. I give lectures for the following companies, but I have not identified any conflict of interest for our topic this morning. So yung HIV tsaka STI co-infection, ano ba yung prevalence niya? Madalas ba itong nangyayari? Well, in a review of 38 studies from developed and developing countries, the overall mean point prevalence of HIV and STI appearing together is 16.3%. And the most common STI are the following. This is in association with HIV. So that's syphilis at 9.5%, tapos gonorrhea at 9.5%, followed by chlamydia and trichomoniasis at 18.8%. And STI prevalence was greatest at the time of HIV diagnosis, reflecting the role of STI in HIV transmission. So, in my lecture, I will ask several questions from our participants and request po sa inyo ay mag-type na lang ng answer. Baka mamaya merong pa-premyo si Rado knows. Baka meron tayong libreng kotse.
Na-pressure
Tignan
naman
natin, ha?
kami.
Sa kotse? Sali ako ha. So in the treatment hub in Manila, what is the prevalence of STI and HIV co-infection? Ano po sa palagay niyo? So yung pinakita ko sa inyo na 16.5%, that's globe ito sa isang tertiary hospital sa Manila, ano kaya? So I'm seeing letter B and letter C, but in this study, 33% yung co-infection rate. So ano yung mga STIs na nakita? So ayan. So 33.5% yung co-infection rate. So that means almost 1 out of 3 patients na na-diagnose with HIV ay merong concomitant na sexually transmitted infection. And ito po yung mga list na nakita nila. Okay, so ang prevalence ng anogenital warts to those who were ever tested is 15.78%. So mataas din yung syphilis. So yung confirmed syphilis, it's at 6.51%. Yung patients who are only screening positive, it's at 11%. Tignan natin, kasi nakita ko dun sa Murat kanina, di ba? Marami daw silang nakikita na gonorrhea. So in this clinic, yung urethritis, hindi siya ganun kataas, 2.38%. And based from this study, yung patients with at least one sexually transmitted infection, as I've said, is 33.49%. And those with multiple sexually transmitted infection at the same time, merong ganun at 5.13%. So, yung HIV and STI, ang tawag natin dito is syndemic. So, narinig na natin yung pandemic, narinig na natin yung epidemic, di ba? Tapos, naririnig natin yung endemic. Sabi natin, di ba ngayon, yung COVID-19, mukhang papasok na tayo sa endemic. So, today, i-introduce ko sa inyo yung term na syndemic. Ano yung ibig sabihin ng syndemic? This means that yung interacting, yung co-presentation or sequential diseases. Okay, so ito yung mga, for example, two diseases such as HIV and STI, they interact with one another, they present together, or minsan they present one after the other, whose social and environmental factors amplify. Okay, so it amplifies the negative effect of disease interaction. So once you have one and the other, ibig sabihin it's going to be a bad combination. Example, people with an STD or STI may be at an increased risk of getting HIV because you do have the same behaviors and circumstances that put one patient at risk for both HIV and STI. So that's sexually transmitted route. And having a sore, may sugat dun sa genital area or a break in the skin from a sexually transmitted infection will actually allow HIV to easily enter the body. On the other hand, yung sexually transmitted infections naman can increase the risk of spreading. So, maaaring mas mataas yung risk na maipasa mo yung HIV kapag ikaw ay mayroong gonorrhea or urethritis. People with HIV are more likely to shed HIV when there is urethritis or genital ulcer, kapag may sugat dun sa area brought about by a sexually transmitted disease. Okay. So, yung now let's proceed to the different approaches to the treatment of sexually transmitted infection. Tatlong paraan kasi on how we diagnose STIs. Number one is via the identification of an etiologic diagnosis. So ibig sabihin ito, gumagamit tayo ng mga laboratory test, mga clinical diagnostic test to identify kung ano ba yung nagkakos na bacteria or virus dun sa ating sexually transmitted infection. So, dito sa atin, syempre, very limited yung access natin sa diagnostic test. Or kung meron man tayong access sa diagnostic test, kadalasan di ba mahal. So, kadalasan ang nangyayari, we perform our treatment and management and diagnosis is via the clinical diagnosis approach. So, ibig sabihin, we use the clinical experience. So, ginagamitan natin ng history and PE, to identify the symptoms which are very typical for a specific UTI, tapos we come up with a most likely diagnosis to explain what the patient has. Now, meron tayong tinatawag syndromic case management. This is management based on the patient's symptoms. So, halos magkamukha yung clinical diagnosis tsaka syndromic case management. But sa clinical diagnosis kasi, you come up with a single diagnosis. Okay? Kung ano yung diagnosis mo, yun yung gagamutin mo. Pero when you talk about syndromic case management, you follow an algorithm based on what or how the patient presents with. So, pagtuunan natin ng pansin yung syndromic case management. So, this syndromic case management is based on what you observe that a number of different organisms can cause STI, giving rise to only a limited number of syndromes. So, ibig sabihin, marami mang mga iba't ibang causes ng sexually transmitted infection na bacteria or virus or even protozoan, pero kadalasan, the way they present, kung paano sila nagpe-present sa ating mga pasyente ay halos magkakamukha. So, ano yung mga syndromes na yon? So, before I proceed, ano muna ba kapag sinabi natin na syndrome? When you say syndrome, ano yung definition niya? Is it a diagnosis based on history and PE? Is it the patient's symptoms and your physical findings? Is it a diagnosis based on laboratory test? Or is a syndrome a list of diseases considered to cause STI? So I'm seeing a lot of letter Ds. Again, thank you for your participation. Some I see letter B. So it's a toss between letter B or letter D actually. And the correct answer is actually letter B. So pag sinabi niyong syndrome, yan ay patient's signs and symptoms plus whatever you find on your physical examination. So a syndrome is a group of symptoms that a patient complains about and the clinical signs that you observe during your physical examination. So ito yung list ng mga syndromes. So meron tayong vaginal discharge, merong urethral discharge, merong genital ulcer, meron kang inguinal bubo, yung merong mga malalaking mga bukol or kulane sa singit, lower abdominal pain, usually pelvic inflammatory disease among females, scrotal swelling, and neonatal conjunctivitis. Okay. So this table I got from the World Health Organization guidelines on the syndromic management of STIs, and makikita natin dito na nilist down kung ano yung mga syndromes na madalas, ano yung mga kadalasang symptoms associated with that syndrome, and ano yung mga physical findings that you see there, and ano yung most common pathogen, ano yung most common disease. So tignan natin let's say your male patient presents with a urethral discharge. Ano yung mga posibleng mga complaints ng pasyente sa iyo? So the patient can present with tulo, may nana na lumalabas sa are, urethral discharge, masakit kapag umiihi or madalas siyang umiihi, frequent urination. And when you look at the penis of the patient, meron kang makikitang urethral discharge. You can even ask your patient na milk yung ari niya kapag minsan kasi kapag kaunti lang yung lumalabas na discharge, hindi siya ganun ka-florid kapag tinignan mo lang. Sometimes you have to ask the patient to milk para makita mo na meron talaga siyang discharge. Or sometimes pwede mong tignan yung yung underwear ng patient, and when you see na kapag merong mga mantsa-mantsa, then you can assume na meron talagang nagka-come out na discharge from the penis. And ang mga common na pathogen presenting with a urethral discharge syndrome would be gonorrhea tsaka chlamydia. So pag sinabi naman nating genital ulcer, so ibig sabihin the patient will present as a sugat, a genital sore, a swelling dun sa genital region. And syempre kapag tinignan mo, then you will notice or you will note the genital ulcer. And for this syndrome, so it causes syphilis, chancroid, and genital herpes. So yung lecture ko po, na yung time allotment sa akin is not enough for me to cover all of these syndromes. So I will provide you with a copy of my lecture, and also yung sa mga reference ko, makikita niyo naman po yung most recent version ng Syndromic Management of STI by the World Health Organization, released in 2021. So you can always go back to that reference. Okay. So ang advantages and features ng syndromic case management is that it is problem-oriented. So you respond, yung action mo is based on how the patient's symptoms presented. This approach is highly sensitive and does not miss mixed infection. Later on, you will see kung bakit hindi na-miss yung mixed infection. You have, or this allows you to treat your patient on that same visit. So remember na isa sa mga dictum, kapag naggumagamot ka ng isang pasyenteng nagsususpecha ka na merong sexually transmitted infection, ay dapat before you send that patient home on that same visit, bigyan mo siya ng necessary treatment. Dapat hindi mo siya pababalikin, tapos pagbalik ng lab result, saka mo lang siya gagawin. So we try to avoid that. Okay? We want to initiate treatment at first visit. This syndromic case management makes STI care more accessible because yung use of the algorithm that I will show you later can be implemented at the primary healthcare level. It uses flowcharts that guide healthcare workers through logical steps on how to treat the patient. And it also provides the opportunity and time for education. Kasi sa dulo ng algorithm, there are points there on what you can tell your patient on how to prevent yung getting the infection in the future. So, back in 2017 or even before the 2021 version of the guidelines by World Health Organization, okay na yung syndromic management. But in the most recent version, ang sinasabi nila that although this syndromic case management of STI has a high sensitivity, in general, hindi gano'n kataas yung specificity niya. So, ibig sabihin, this can lead to overtreatment of our patients. So, ang sinasabi nung sa most recent version of the guideline is that yung rapid or point of care test that should be available within the day, these have been incorporated in the guidelines in implementing the syndromic management of STIs. However, nire-recognize ng WHO na kadamihan talaga naman sa mga resource-limited setting, wala naman talagang access sa rapid or point of care tests that are available within the same day. So they still incorporated the things in the algorithm to do kapag walang available na testing. So I am referring to the different rapid or point of care tests that are available, that should be available within the day. Ano-ano yung mga yon? Direct microscopy. So meron kang slide, tapos meron kang microscope in your clinic. You can directly check the vaginal secretions kung merong clue cells. You can right away perform gram staining para makita mo kung kaunti ba yung gram-positive bacilli. Or you can perform gram staining using yung discharge cramming from the penis of the patient, kasi pag nakita mo na maraming gram-negative diplococci, then you're almost sure that the patient has gonorrhea. Other test na mabilis lang at pwedeng gawin sa clinic at nire-recommend na gawin sa clinic is the performance of KOH slide test, particularly kung ang patient ay merong curd-like discharge, tapos nagsususpetsa ka na merong candidiasis si patient. I know that the Department of Health sometimes provides us with free rapid serologic test for syphilis. I use this a lot in my clinic. And in some institutions, merong gene expert for the detection of gonorrhea and chlamydia from the urine. And this is usually available in about 2 hours kasi medyo mahal siya. The cost is about 6,000 to 7,000 pesos. Pero ang bilis mong lalaman kung meron pang gonorrhea or chlamydia si patient among those na nagpe-present ng tulog or urethritis. So, ang next part na ng lecture ko would be case presentation na tayo. So, I think I have 3 or 4 cases. This is my first case. Si Miguel, he is a 26-year-old male who presents with anal pain. He noted lesions that started as bootleg and then multiplied and eventually pumutok. So, nung nagpakita si patient sa clinic, wala na akong nakitang bootleg, pero mga sugat na maliliit yung nakita ko. This is the first episode of this sugat na medyo marami sa paligid ng puwet ni Miguel, but he told you that he had previously experienced 2 instances in the past na nagkaroon daw yung perianal area niya na moist tsaka mabaho. But nothing similar to this one. This patient engages in MSM with last unprotected anal contact 3 weeks ago. Okay? So, ano po yung syndrome na nag-present si patient? So, can you type your answer in the chat box? So, babalik ko dun sa slide na meron tayong different syndromes. Anong syndrome kaya yung gagamitin natin? Because mahalaga yun eh. Yung pagpili natin kung anong syndrome is very important para malaman natin kung anong algorithm yung gagamitin. So, yeah. So, some of you are answering anal sore, painful ulcer, genital ulcer. And you're correct. Dito tayo sa genital ulcer na syndrome, and therefore we will use the genital ulcer na algorithm. So, tignan natin kung ano yung genital ulcer na algorithm. So ito yan. So for patients who present with symptoms of genital ulcer, we have to take the medical and sexual history and assess the risk of the patient for STI. And of course, we always look at the genital and perianal areas. So you have to confirm, meron ba talagang sugat o wala? So kung ang sagot mo ay wala namang sugat, okay, then you don't have to treat the patient. Maybe you have to offer HIV and syphilis testing because you know na a patient with syphilis can present initially with a genital ulcer, but even without treatment, pwedeng mawala on its own yung genital ulcer na yon ng syphilis. And then you ask your patient to follow up after 1 week to see kung kumusta na yung symptoms. But what if pag-perform yun ng physical examination, meron talagang ulcer, meron talaga kayong nakita. So you ask yourself, is your institution, meron ba tayong resources and capacity for molecular testing? Meron ba? Kasi kung meron, then we perform the test, and whatever the results of the test is, then we treat accordingly. So kung halimbawa, meron tayong testing for herpes simplex in our institution, PCR, HSV PCR, then we perform that test. Tapos kapag kung mag-positive yun, then we treat as herpes simplex infection. But most of the time, dito tayo sa gitna mapupunta, di ba? There is the presence of the ulcer, but we have very limited or no laboratory capacity. So then we ask ourselves, is the ulcer vesicular or is there a history of recurrent ulcers in the same site? So sa atin, pwede nating sabihin yes eh. Okay? So if the answer is yes there, then we treat for herpes simplex virus infection. Okay? And then we ask, is there a history of recent syphilis treatment the past 3 months? If the answer is yes, then we don't have to address the syphilis already. At that time, hindi natin kailangan mag-initiate ng treatment. But what we do is we test for syphilis. Okay? But if there is no treatment for syphilis, then in the past 3 months, then we go ahead and treat and give benzathine penicillin G. Okay? So let's go back to our patient. What will you do dun sa ating pasyente? Are you going to give acyclovir? Letter B, are you going to give acyclovir tsaka benzathine penicillin G? Are you going to give benzathine penicillin G? Or letter D, are you going to give acyclovir and request for RPR VDRL? I'm seeing a lot of letter D's. Yeah. So balikan natin ha. Oo. So I think ang answer ko kasi dito ay letter D. So tingnan natin kung bakit letter D. Because, okay, so it seems that the patient has a history of vesicles. So yes, we treat for HSV, but we don't have any recent test, di ba? For syphilis the past 3 months. Okay. So the answer is no. So we also have to treat for syphilis. But of course, sabi dito sa algorithm, we still offer HIV and syphilis testing. So kung babalikan natin yung tanong, parang pwede rin kasi yung no? Yung letter D. Oo. I think the correct answer should be a combination of letter B and letter D. So, magbibigay ka ng acyclovir, magtitreat ka ng benzathine penicillin G, but you will also request for syphilis testing. So, I can accept letter B and letter D. Kasi the correct answer is a combination of both. So, let's talk about genital herpes simplex infection. Yung HSV2, this is the most common cause of recurrent genital ulcer worldwide. Most primary or initial infection are actually asymptomatic or atypical. And there is an epidemiological synergy with HIV transmission. And HSV2 patients are treated times more likely to become infected with HIV. Yung HIV and HSV2 co-infection are more likely to transmit HIV to the others. Meron din kasing HSV1 infection eh. Diba? Pero yung HSV1 infection, the symptomatic episodes when you have HSV1 are less likely and are less severe than the first episode. So kung HSV1, the worst is the first episode, and then very infrequent na lang yung subsequent episodes, and in case there will be any, mas kaunti na siya or mas benign na siya compared to the first episode. But for HSV2, usually you have one or more symptomatic recurrences within 1 year after the first symptomatic episodes. And the infection typically leads to intermittent viral shedding. So a patient can be infectious even if walang active lesions, and often transmitted by people who are unaware of their infection or who are asymptomatic at the level at the time of the sexual contact. So how do we treat genital HSV? In the past, lalo na kung medyo delayed yung consultation ng patient, there is an option to actually not start anything kapag when you are dealing with HSV infection. But the most recent guidelines tell us that for adults and adolescents with a first clinical episode of genital HSV, the guideline recommends to start treatment over no treatment. Okay? And ito po yung recommended na dosage for the following instances. For primary infection, your first line option is actually acyclovir, 400 milligrams, 3 times a day for 10 days. Or acyclovir na 200 milligrams orally, 5 times a day for 10 days. Okay? Tapos, meron tayong mga substitute. For example, dito sa Pilipinas, valacyclovir is also available. It's given 500 milligrams twice a day for 10 days. Okay. For patients with recurrent infection, halimbawa more than 4 to 6 weeks yung recurrences niya in a year, so that's very bothersome for the patient, then you can give acyclovir 400 milligrams 3 times a day for 5 days, or acyclovir 800 milligrams orally twice a day for 5 days. So medyo complicated yung dosing recommendations. I don't expect you to memorize them, but at least you know where to look for the doses. So ito po yung document na sinasuggest ko na gamitin nyo for these dosing recommendations. Again, yung guidelines for the management of symptomatic sexually transmitted infections developed by the World Health Organization in 2021. So meron din tayong tinatawag na suppressive therapy. So for those na masyado talagang recurrent at mabilis malik yung genital HSV nila, pwede natin silang simulan ng acyclovir na 400 milligrams orally twice daily. Okay? And the suppressive therapy for recurrent herpes is this one. Yung duration niya, it really depends on whether makontrol natin yung number of recurrences. So you can place your patient for 3 to 6 months on this suppressive therapy. And then you discontinue the suppressive therapy kapag hindi na ganun ka recurrent or hindi na nagre-recur yung HSV infection ni patient. Okay? So let's proceed with case 2 unless you have questions on genital herpes. Sige, type nyo lang or taas nyo lang yung kamay nyo. And Rad, help me na i-call kapag meron. So next case, we have a 33-year-old male with 3-day history of fever and rash. So in that span of 3 days, yung rash niya ay nag-progress. Hindi naman makate, it's also non-painful, pero there was already discomfort. It initially started on the chest, but now it already involves the entire body. And this is associated with generalized, non-painful, slightly enlarged na lymph nodes. Kulane. So the patient engages in MSM and occasionally uses condoms. He had a new sexual partner 7 days ago. So ito, this is the actual picture of my patient. Ayan. So what you see here is a generalized erythematous non-tender maculopapular rashes. Okay, varicose, iba-iba yung laki. Meron sa palms and soles, tapos meron din sa trunk. So meron sa chest, meron din sa abdomen. Okay. So what is your diagnosis for this patient? So is it monkeypox? Is it secondary syphilis? Is it varicella zoster? Is it shingles? Ayan. Marami sa inyo nagsasagot letter B. Oo. Sige. So the correct answer is letter B. Hindi siya monkeypox kasi usually 'di ba yung sa monkeypox, it start out as papules tapos ano siya, nagiging ano tawag doon, umbilicated. So yung lesion para siyang pimples tapos nagkakaroon ng parang butlig sa gitna. Ganun yung monkeypox. Whereas for secondary syphilis, the lesions are very generalized. Tapos ang description natin ay maculopapular na mapupula na rashes. Hindi siya varicella zoster, hindi siya bulutong kasi alam naman natin na kapag bulutong ay generalized din yung distribution tapos butlig tapos yung iba naglalangip at different stages of the infection. And yung shingles, very ano siya, confined to a single dermatomal distribution only. So, most likely for this case is secondary syphilis. Siguro ang tanong niya sa akin, Doc, anong anong syndrome yung ginamit natin para ma-diagnose ito? Unfortunately, for secondary syphilis, it's not part of any of the syndromes because remember that secondary syphilis is the time na yung syphilis, yung spirochete, yung treponema pallidum ay nagsi-circulate na in the blood. So there's spirochetemia already. So maybe this is a very special group of sexually transmitted infection that we can lump together with HIV and hepatitis B and hepatitis C. Those that are found in the bloodstream and causes systemic infection. So that's a very special group of sexually transmitted infection. Okay. So, for this case, nag-perform ako ng rapid syphilis 3.0 test, yung sa BioLine, standard diagnostics. It was actually positive. Pero nag-request pa rin ako ng RPR quantitative. It's 1:32 and this was available on follow-up na. Nagawa ko na yung rapid syphilis test on that same day. Available in about 20 minutes. So right there and then, I treated the patient with benzathine penicillin G, 2.4 million units IM single dose. And sa clinic po, kadalasan I use as a diluent lidocaine na 2%. Okay? So the lesions after the patient received the benzathine penicillin G became less palpable and slightly hyperpigmented na. Tapos nag-start na siyang magbalat after 3 days. And after 1 week on follow-up, halos complete healed na lang yung lesions maliban sa medyo nangingitim na lang siya, which is very common naman kapag nagtitreat tayo ng secondary syphilis. So, let's talk about syphilis infection. Yung primary syphilis, chancre, ang tawag po natin to. Ayan, kung ang pasyente ay merong hard chancre, this presentation can fall under genital ulcer. So, there's painless, indurated, well-defined borders na genital ulcer with inflammation that is predominantly lymphocytes and plasma cells. And take note na this is painless. So, yun yung problema natin sa syphilis eh. Because it is painless, sometimes the patient is unable to note na meron pala siyang syphilitic lesion sa penis. Minsan kung ang lesion mo ay nasa ilalim ng ari, mahirap talaga makita ng pasyente yan. And the problem with syphilis is in 2 to 8 weeks, even without treatment, it will go away on its own. Okay? Pero ibig sabihin na magaling ka na. It will proceed to become secondary syphilis, which is what the patient had. Okay, remember that secondary syphilis is the stage where dissemination occurs, and this presents with fever, rash, and swollen lymph nodes similar to our patient. And ang remind ko po sa inyo, tatandaan niyo ito parati. When you are examining a rash in a patient, always wear your gloves because note that primary and secondary lesions, itong rash na nakikita niyo po dito sa pasyente, these are rich in spirochetes and they are highly infectious. So you should always use your gloves when examining these rashes. Okay? So I want to discuss with you some available diagnostic tests for syphilis. Yung serologic test natin for syphilis are divided into two. So meron tayong tinatawag na non-treponemal, tsaka meron tayong tinatawag na treponemal antibody test. So yung non-treponemal, these are screening tests, they are easy to perform, and ang example po niyan ay yung RPR tsaka VDRL. Okay. So, ginagamit po natin yan pang screen. Tsaka ginagamit din po natin yung non-treponemal test, halimbawa yung VDRL tsaka RPR quantitative, para i-check kung bumababa na yung titers ng pasyente. So, kung halimbawa ang baseline titers niya ay 1:32, after 1 month, you repeat your RPR na quantitative, bumaba na siya by 4-fold, naging 1:8 na lang siya, then ibig sabihin, nag-work yung treatment. Now, for patients that turned out to be positive for non-treponemal test, you have to confirm if that is true. Because sabi ko nga, screening lang ang non-treponemal test. So, ang mga confirmatory test natin are called treponemal antibody test. The problem with your treponemal antibody test ay they remain positive for life. So example ng mga treponemal antibody tests are those that start dun sa TP. So pag nakita nyo ng TP-PA or TP-HA or TP-EIA, then that's usually a confirmatory testing for your syphilis. And ang iba pang sikat na confirmatory test would be your FTA-ABS tsaka yung MHA-TP. Okay. So, ito po yung treatment natin para sa syphilis. In general, yung syndromes or symptoms that syphilis presents with can fall under early syphilis or late syphilis. So, ano-ano ba yung mga early syphilis? So, yung primary syphilis, yung chancre, when you have secondary syphilis, or when you have early latent syphilis, then isa lang po ang treatment niya. So that's just a single dose of benzathine penicillin G, 2.4 million units IM. Single dose. Okay? So as much as possible po, when you are treating syphilis, use penicillin. Okay? Do not use the alternatives because we do not know how effective these alternatives are. Kasi po marami akong nakikita na ayaw mag-inject, ang binibigay na lang ay doxycycline. Okay? Please, let's not do that po. Remember that the preferred treatment for syphilis, if the patient is not allergic, especially, we give benzathine penicillin G. Okay? Pakitandaan po yan, ha? And yung mga late stage syphilis is actually yung latent syphilis lang siya. So when you say latent syphilis, this is a patient, halimbawa, na pinapunta sa inyo, yung mga seaman for pre-employment na wala namang nararamdaman, tapos nare-refer na lang sa inyo na positive yung kanilang RPR or VDRL. Okay, so kapag ganon, wag niyo sila agad i-treat. Mag-request po kayo ng confirmatory test, yung TPHA or TPPA, and kapag negative yung confirmatory test, then you don't need to treat the patient. Kapag positive, then that's the time that you treat. And you just check if the seroconversion happened in 1 year, then kailangan lang natin ng single dose. Pero kung hindi natin alam kung kailan siya nag-positive, then we treat as late latent syphilis. So ang gamutan po ng late latent syphilis ay ganun pa rin naman. Benzathine penicillin G, 2.4 million units once a week, pero 3 weeks po siya. So that's a total of 3 doses. So again, ang suggestion ko po sa inyo, kawawa naman kasi yung mga patients na nag-i-inject tayo ng penicillin, mas makapal kasi yung penicillin G. So I use a diluent, yung 2% lidocaine na 2.5 ml tsaka 1 ml ng sterile water for injection. And make sure na kapag mag-i-inject po kayo, do not use yung gauge 23 needle. Use at least a gauge 21 needle para hindi po magbara yung hiring gila. Okay? So, meron ba tayong question? Pakiulit yung diluent. So, in 1 vial ng benzathine penicillin G, so that's usually 1.2. Sa isang vial po kasi 1.2 yun. So, ang ginagamit ko pong diluent ay 1 ml ng sterile water tsaka 2.5 ml ng 2% na lidocaine. So, ang kailangan nyo kasi per dose, 2.4 million units. So, ang ginagawa ko, yung isang 5 ml ng 2% na ampule ng lidocaine, hinahati ko yun, 2.5 ml sa isang vial, 2.5 ml sa kabilang vial. Tapos on each vial, 1 ml ng sterile water. For primary or secondary syphilis, we give PENG on first visit without baseline titers. Yes po, if you are considering already syphilis, you give it and then you just request for baseline titers on follow-up. Doc, pag allergy po ang patient, doxy ang bibigay. That's correct. We have no choice. Ang sinasabi ko lang po kanina is when you can give penicillin G, then give penicillin G. So kung sinasabi ni patient that he or she is allergic, then that's okay. Give doxycycline, but you have to monitor your patient closely because doxycycline is an alternative treatment only. Yan. Salamat po for your questions. Next, case 3. RD is a 30-year-old male Canadian gun seller. Complaint of scanty mucoid penile discharge. Ito po yung picture. So hindi siya purulent, hindi siya madilaw na madilaw, tapos kaunti lang siya. Tapos this patient is also complaining of dysuria of 2 days duration. The last unprotected sexual intercourse was 7 days ago with a girl he met inside a convenience store. So nagkatinginan lang daw sila. There were no genital ulcers. The meatus was with scanty whitish mucoid discharge na slightly mapula. You saw him at 5 p.m. in the clinic on a Saturday, and yung sa hospital po kasi namin, hindi ginagawa yung rapid na gene expert kami dyan ng weekends. So, ang next testing na ay Monday. Okay? So, ano ba yung question ko dito? So, for this patient, what is the syndrome? So, anong syndrome kaya yung gagamitin nyo kay foreigner? This is a foreigner, I think. Yeah. Yeah, so you are saying urethral discharge, penile discharge. Yeah, tama kayo. So you use the penile discharge na algorithm or syndrome. But before I proceed, may nakita akong question eh. Doc, what if ang available po is 1 million unit? Okay lang po ba i-reconstitute para ma-achieve yung 2.4? Hindi po. Ganito po yan. Ang available na formulation ng benzathine penicillin G ay 1.2. So, ang available po na 1 million unit ay benzyl penicillin. So, hindi po yun yung tamang formulation ng penicillin. So, again, let's differentiate ha. Ang ginagamit po sa pag-treat ng syphilis ay benzathine penicillin G or benzathine benzyl penicillin G. So, yung 1 million unit na formulation, that's benzyl penicillin po. Hindi po yun ang gagamitin natin dapat because that should be given intravenously at mas maikli yung half-life niyan. So let's make sure na ang ginagamit natin ay benzathine benzyl penicillin G. And the formulation po nun is per vial 1.2 million units. Okay? So yung 1 million unit po yan, that's benzyl penicillin. That's your aqueous penicillin G. So I hope malinaw po yun, ha? Don't be, let us not be confused about the different types of penicillin G. Sige. So let us discuss urethral discharge from the penis. Okay, so when you have a person with symptoms of urethral discharge coming from the penis, you take your medical and sexual history and examine if there's any discharge, of course. And then you ask yourself, madali naman kasing i-assess talaga eh, kung meron bang discharge or wala. When the discharge is very scanty, ako talaga nakikita ko, tignan niyo yung PreP, kung merong mancha. Kasi that will tell you kung meron ba talagang kung meron ba talagang discharge or wala. So, ang next question kasi dito ay, kaya nyo bang mag-perform ng molecular assay? Kasi kung limited yung laboratory capacity nyo, you are unable to test. Then, nalaman nyo na meron talagang discharge, no way kayo. You have to treat for both gonorrhea and chlamydia at the same time. So, kapag tinignan nyo yung on physical examination, there's no urethral discharge, okay? Then you proceed to offer HIV and syphilis testing, okay? And then you ask your patient to follow up after 1 week. So, kung no ang sagot nyo, for example, the patient complains of something pero on physical examination hindi nyo nakita, then you still offer routine testing for HIV and syphilis and advise the patient to follow up after 1 week. Ngayon, kung kayo ay nagpa-practice sa isang private hospital, like for example, tapos available yung gene expert or molecular testing for gonorrhea and chlamydia, then that's best. Kasi kung nagawa mo yon tapos nag-positive ka lang sa gonorrhea, then you just treat for gonorrhea. Kung nag-positive yung test mo for chlamydia at negative for gonorrhea, then you just treat for chlamydia. But you still offer your HIV and syphilis testing as part of routine screening for your HIV and STI. Okay, so for this patient, what is the appropriate treatment regimen for RD? So do you give ceftriaxone IM single dose plus azithromycin, no 1 gram single dose? Do you give cefixime plus doxycycline? Do you give ceftriaxone IM or doxycycline? Or letter D, you give tetracycline for 7 days? Yeah. Actually, I think there are 2 answers here. And I think most of you are answering it correctly. So, you are answering letter A and letter C. Okay? So, ito po yung treatment recommendations natin. Okay? So, again, ang target natin dito is gonorrhea tsaka chlamydia. If we are unable to test. Kasi kung na-test natin tapos sinabi na gonorrhea lang, then we just treat for gonorrhea. Kapag ang nag-positive lang ay chlamydia, then chlamydia lang i-test. Yung test na ginagamit ko po na Gene Expert, it's the same Gene Expert machine for TB, but you use a different cartridge. So ang cartridge po na ginagamit nila is urine specimen for GC clam, gonorrhea chlamydia testing. So for gonorrhea, you give ceftriaxone 250 single dose plus azithromycin. Okay? For chlamydia trachomatis, okay, you give doxycycline. Okay? So, meron tayong mga substitute, halimbawa yung paggamit ng cefixime plus azithromycin. But usually right now, what we want to give our patient is ceftriaxone because ceftriaxone will clear the pharyngeal colonization ng Neisseria gonorrhea. Okay? So, looking at this table, when you are treating singly for gonorrhea, then you give ceftriaxone plus azithromycin. And the choice of this, the reason for this combination is that they are both active against gonorrhea. Especially in areas na medyo mas mataas na yung resistance rates ng gonorrhea, they prefer using 2 agents against gonorrhea, which would include ceftriaxone and azithromycin. But for chlamydia, there's a preference for the use of doxycycline. Okay. Alternatively, you can give azithromycin or erythromycin or even ofloxacin. Okay. But usually, ang first line natin is doxycycline. Okay. So in settings in which the local antimicrobial resistance data reliably confirm the susceptibility of gonorrhea to be fully susceptible naman at wala tayong problems of resistance, similar to what we have in the Philippines with our limited isolates ng gonorrhea, then we can give ceftriaxone, single agent, kahit na hindi na natin samahan ng azithromycin. Okay, so additional therapeutic options for recurrent or persistent infections is the treatment for Trichomonas vaginalis, which is metronidazole, tsaka yung Mycoplasma genitalium, again, azithromycin 500 milligrams. So that's 2 to 5 days na 2 and 1/2 tablets. Just recently po, I think 2 weeks, I had the foreigner na ginamot siya for chlamydia. After 2 weeks, meron pa rin. So he consulted me. Ginamot ko siya for gonorrhea. After 2 weeks, meron pa rin na kaunting discharge. Kumaunti, pero meron pa rin talaga siya na kino-complain. So, ang ginawa ko, nagpa-direct smear ako ng urethral swab at nagpa-gene expert ako. Apparently, the patient was negative for gonorrhea, positive for chlamydia, and medyo na-surprise ako kasi merong nakita na Trichomonas vaginalis. So, kaya pala medyo persistent kasi meron pala siyang trichomoniasis, which resolved after 7 days ng metronidazole. Okay. So, minsan magkakaroon kayo ng question about the difference in the dose. Because in the US CDC, ang dosing recommendation nila ay ceftriaxone na 500 milligrams IM. Pero sa WHO, it's just 250 milligrams. Okay? So the reason for this is I think the US is seeing more cases of drug-resistant na gonorrhea. Kaya ang ginagamit nila is 500 milligrams instead of your 250 milligrams. Okay? So going back, I think I can accept A or letter C to this. But I think the most appropriate in our setting would be ceftriaxone and doxycycline. For gonorrhea, let's discuss shortly. The male to female transmission is more efficient than male to female. Than female to male. Yeah. And the most common clinical manifestation in men is acute urethritis. And for females, kapag merong gonorrhea, it's usually presenting with profuse and purulent discharge. There's cervicitis, tsaka there's vaginitis. So when you do your gram stain in your clinic, then you will see this intracellular gram-negative diplococci. And this is usually diagnostic of a gonorrhea infection, especially for males. Okay? In females, it can be a probable na urethritis because there are other non-gonococcal na Neisseria species in the vaginal area. Okay? So treatment of sexual partner, yung mga recent partners ng patients na na-diagnose ng gonorrhea. For example, yung mga persons having sexual contact with the infected patient within 6 days preceding the onset of symptoms, they should be referred for evaluation testing and presumptive treatment, both with ceftriaxone and doxycycline. If the patient's last potential sexual exposure was more than 60 days before the onset of symptoms, the most recent partner should be the ones treated. So to avoid reinfection, yung sex partner should be instructed to abstain from unprotected sexual intercourse for 7 days after they and their sexual partners have completed treatment and after resolution of the symptoms. So 7 days yung waiting time. Next, case 4, si Lucy, a 29-year-old female on ARVs since 2019, and yung last VL niya was undetected, consulted 3 days ng vaginal discharge, initially presenting with itchiness around the perineal area. The last sexual intercourse was 6 months ago without a condom from an acquaintance. On PE, you noted brownish to yellowish discharge with redness of the vaginal area. Okay? So, for this patient naman, ang gagamitin natin is vaginal discharge na algorithm. So, for a person who presents with vaginal discharge, okay, you always perform your PE and history taking, okay? And you perform always your bimanual digital examination of the vagina. Because if the patient is positive for bimanual exam, ibig sabihin you try to touch on the cervix, tapos on top of the hypogastric area, pinapress down mo, tapos may pain na naramdaman yung pasyente, then that patient is suspected to have PID and you might have to refer that patient to a secondary or tertiary care for IV administration. Next thing that you would have to do is to look kung ano yung mga diagnostic test na available in your clinic. So meron ka bang available na test for gonorrhea, chlamydia, or even Trichomonas vaginalis, yung direct sputum wet mouth examination? Can you perform speculum examination? Okay? But most of the time, ang answer niya sa akin, hindi. So speculum cannot be done, tapos no available test. So what do you do? So, you check, is the vaginal discharge present on genital examination? Kapag yes, then you still treat with gonorrhea, tsaka chlamydia. So, ibig sabihin, ceftriaxone yan, tsaka doxycycline or azithromycin. And next, kung wala, you ask, is the woman at a high risk for STI? Okay? Kapag ang answer nyo ay yes, kahit na wala kayong nakitang vaginal discharge, you still treat as gonorrhea and chlamydia. Tapos, you still offer your HIV and syphilis testing. Okay? But also, you have to consider bacterial vaginosis, especially when the discharge of your patient is just thin and mucoid, tapos hindi siya ganon ka-florid. And ito yung kagandahan if you can perform at least yung gram stain. Okay? When you see a lot of different morphologic bacteria, tapos kaunti lang yung gram-positive bacilli, then you think of an imbalance in the vaginal flora, and that patient might be having bacterial vaginosis. So baka kailangan yung mag-treat ng metronidazole on top of your doxycycline tsaka ng ceftriaxone. Okay, so ito yung criteria ng bacterial vaginosis. Okay, so you can look for clue cells, you can check on the pH, and you can note for fishy odor when you add 10% KOH. Okay. For gonorrhea, or there's a question here, for gonorrhea or chlamydia co-infection, is it ceftri plus acid or doxy or acid and doxy? So sige, let's just clarify it. It's ceftri plus doxy. Yeah. So this is how you treat bacterial vaginosis and trichomoniasis. The recommended regimens, yung metronidazole at the following dose. Okay. Alternatively, you have tinidazole, which is not available, and clindamycin. Okay. So this is a picture of one of my HIV-infected patients na mayroong recurrent na mass sa puwet. Okay. Because of the recurrent mass, he has undergone several cauterization and removal of the mass. I advised him to undergo HIV testing, which turned out to be positive. Nung nag-start na siya ng ARV after 3 months, hindi na nag-recur yung mass after the last na cauterization and removal. So this is an example of anogenital warts. Okay. Most sexually active people get HPV at some time in their lives, although most never know it, and they are able to clear it in 1 to 2 years. And just take note that partners who have been together tend to share HPV, and it is not possible to determine which partner transmitted the original infection. So wag tayong mag-away because we don't know kung kanino nagsimula yung initial infection. So having HPV does not mean that a person or his or her partner is having sex outside the relationship. For all we know, the infection could have occurred way back in the past already. Okay, so just remember that HPV 16 or 18 is found most frequently in cervical carcinomas, and less commonly you can have HPV 31. But your HPV 16 and 18 are responsible for 70% of all cervical cancers, with type 16 being the most common. Okay? The types of HPV that cause genital warts are different from the types that cause cancer. Okay? There is no effective antiviral regimen currently available. So for warts, they can be removed surgically or through chemical ablation. So you use 90 to 100% na TCA, trichloroacetic acid. Sometimes you can give your yung cryotherapy. Some would use for small lesions less than 5 millimeters and also flat, pwede tayong mag-trial ng imiquimod ointment. And there is a vaccine available against HPV. So meron na tayong bivalent, meron din tayong quadrivalent, and meron tayong non-valent na vaccine against HPV. Okay? So, just for your information, i-run down na lang natin yung iba pang mga algorithms available. Yung lower abdominal pain, tapos meron din tayong scrotal swelling na algorithm. Meron din tayong flowchart for inguinal masses, inguinal lymphadenopathy. Tapos meron din tayo for, ano ba to? Neonatal conjunctivitis. Okay, so I will provide you with a copy of my lecture and you can use it as a reference when you have patients like that in the future. So for MSM, we screen at least annually for syphilis, genital chlamydia, and gonorrhea, rectal chlamydia, and gonorrhea, especially in those who have had receptive anal intercourse in the past year, and oropharyngeal gonorrhea. So that means for resource-intensive setting, when there is no limitation, you can actually from urethral and pharyngeal swab. More frequent screening every 3 months is warranted for MSM at particularly higher risk for STI. For example, very high risk yung sexual activity. For HIV-infected patients, we screen at the initial visit and then at least annually for chlamydia and gonorrhea, syphilis, trichomonas in women, and hepatitis C virus. We perform one-time screening for hepatitis A and hepatitis B. And then we decide to give vaccine kung hindi sila protected. Or kung positive man sila sa chronic Hep B, then we treat accordingly. Okay. Testing for STIs generally involve a blood test, and this test can be collected by the patient or the clinician. Okay. A positive STI screening test warrants treatment of the STI, but also testing for other co-infections, including HIV. It includes partner notification and management and retesting after treatment, which is usually after 3 months. Okay. Good morning, Doc. Do you still advise vaccine for a PLHIV client or even to those who have sexual encounter already? Yes, I still do recommend, pero you tell them that it's off-label use already. Okay, so I have a few slides on pre-exposure prophylaxis, but I would have to ask si Sinarad kung gaano katagal yung pwede nilang ibigay sa akin for the discussion of HIV pre-exposure prophylaxis.
Hi, Doc. You can go ahead. 10 to 15 minutes. Okay po
Sige,
ba?
Okay, sige. Okay. There's a question here. Is it necessary to treat asymptomatic sexually active women diagnosed with PV? You have to there you have to start with the symptom first. Bakit ka nag-consider ng bacterial vaginosis? And usually bacterial vaginosis would present with vaginal itchiness, discomfort, and even vaginal discharge. So kapag ganon, then definitely you have to treat. But what the question is all about is bacterial vaginosis always sexually transmitted? And the answer is no. So hindi lahat ng bacterial vaginosis ay STI. I'm not sure if that is the question. Anyway, di ba we do have a set of strategies to prevent HIV. So meron tayong HIV testing to diagnose infection, but we also use yung medical male circumcision, improving provision of access to preventive care, but we can also use yung ARV, yung antiretroviral drugs that we use para maiwasan ang HIV. So how do we use our ARVs? So early initiation. Kasi kapag nag-start tayo ng treatment right away tapos the patient becomes undetectable yung viral load, then the patient is not able to transmit the virus. So ang tinatawag natin doon, 'di ba, yung U equals U, yung undetectable equals untransmissible. We can also use our ARVs to prevent the mother-to-child transmission of HIV. But meron tayong pre-exposure prophylaxis tsaka post-exposure prophylaxis for HIV. Yung post-exposure prophylaxis, halimbawa, isang healthcare worker, isang nurse, tapos natusok siya, na needle stick injury siya ng isang needle na gamit sa isang HIV-infected individual, then we can start our post-exposure prophylaxis using a 3-in-1 regimen that can be tolerated by the patient. And that will be taken by the healthcare worker for 28 days or 1 month. But I will focus on pre-exposure prophylaxis. So, yung different effective HIV preventive programs, they do require a combination of this para maging successful yung HIV control natin. Okay? But there is a bad news here. In a regular survey done by UNAIDS in 2020, how many Filipino MSMs reported using condom during the last sex? A, B, C, or D? You're answering letter C, you're answering letter D. The answer is 40% po. It's letter D. Okay? So, if we compare the years 2019 and 2021, ito yung condom use at last sex among the different groups. So, among MSM, bumaba pa. From 50, naging 40% lang yung paggamit. So, people who inject drugs, 15% lang. Okay, for female sex workers, 85%. And for transgender individuals, 41%. So, medyo mababa siya. Okay? So, with all our efforts, it seems na the HIV epidemic in certain areas are still increasing. Kasama na dyan yung Pilipinas. So we have to step up our game in terms of HIV preventive services. And this is the reason why oral PreP containing your tenofovir should be offered as an additional prevention of choice for people at a substantial risk of getting HIV infection as part of a combination of HIV prevention approaches. So it's one of the hindi lang siya mag-isa. It's just a part of this comprehensive preventive strategies. Okay? So as far back as July 2019, there are already 30 plus countries with policies on hindi. So ang pending ay yung mga 30 countries in 2019 with policies on the use of pre-exposure prophylaxis, but all the rest nasa orange, including North America, for example, ay meron ng policy on the use of pre-exposure prophylaxis. And even in the Philippines, there's already an issuance by the Department of Health on the interim guidelines on how to use pre-exposure prophylaxis for the prevention of HIV infection. Okay? So, ang recommendation is oral prophylaxis. Oral pre-exposure prophylaxis containing tenofovir should be offered as an additional prevention of choice for people at substantial risk as part of HIV combination prevention approaches. That's what I've said earlier. And ito po yung mga individuals with substantial risk who will benefit most from pre-exposure prophylaxis. Those who engage in sex with PLHIV who is not virally suppressed yet or whose results of viral load testing is still unknown. Example po niyan yung HIV serodiscordant couple. Okay, na yung HIV positive individual hindi pa siya virally suppressed. So kailangan when they perform sexual contact, dapat yung HIV negative individual should be on pre-exposure prophylaxis. Those having condomless or unprotected anal, vaginal or neovaginal sex in the past 6 months with more than one partner, those with a history of STI in the past 6 months, those who have a sexual partner with more than or equal to one HIV risk factors present in the past 6 months. So in general, these risk factors equate to a high risk of getting HIV because of a virally unsuppressed contact with a virally unsuppressed HIV infected individual or masyadong mataas yung risk niya in the types of sexual activities that the person engages in. Okay. So I will not discuss on the evidences, the exact studies that prove the efficacy of your pre-exposure prophylaxis. Pero ayan, i-quickly flash ko na lang yung magnitude of treatment effect. There's 44% reduction in HIV rate when you start your patient on PreP in this IPREC study. Okay, what else do we have here? Okay, there's no increase in sexual practices na high risk. Okay, so whether or not you cure HIV PreP or not, pareho lang. And even the occurrence of sexually transmitted infection in this study, pareho lang. Kasi yun yung concern, di ba? Ang concern is baka mamaya kapag nag-PreP against HIV, mas maging high risk taking behavior yung patient. And hindi nga nakukuha yung HIV pero he or she gets more bacterial infections. Okay? So apparently mukhang hindi. Okay? So other landmark HIV trials resulted in 80% reduction in HIV infection rate among those given yung PreP ginagamit natin ngayon. So that's emtricitabine and tenofovir. Okay? Okay. So there's already a meta-analysis that looked at the effect of or the benefit of pre-exposure prophylaxis, and it has already shown to be effective, causing a 51% risk reduction in HIV infection. So medyo mataas yan. And the reduction is very much dependent on how compliant the patient is to taking the daily pre-exposure prophylaxis. And not just in clinical trials, but also in other observational studies, it has shown or demonstrated the benefit of HIV pre-exposure prophylaxis. Okay. There's also issue on ARV drug resistance, but in several studies, it's shown that the proportion of people with drug-resistant HIV did not differ among those who received PreP or not. Okay, so this is based on modeling. Okay, yung mga sexual and reproductive health outcomes, medyo some of them would say that there is really no increase risk-taking behavior based on the no increase in other sexually transmitted infections. But some studies would report so, and in a recent study, okay, this is a meta-analysis, they found out na yung rates ng rectal chlamydia seems to be better, higher among those who were started on PreP, but not for the other sexually transmitted infection. So, ang sinasabi lang natin dito is while we start our patient on HIV pre-exposure prophylaxis, we should not depend on that alone, and we should still emphasize the use of other preventive strategies, including barrier precautions for these types of patients. So, meron tayong daily regimen, tsaka meron tayong event-driven regimen or 2-in-1 regimen. Ito yung on-demand na tawagin, kung tawagin natin. So, yung daily regimen, this is given for patients with frequent sex or unplanned sex. So, ang regimen dyan is emtricitabine na 200 mg plus tenofovir. Single tablet lang po yan. So, 1 tablet once a day, it can be taken with or without food, and the maximum dose is 2 tablets per day for adult, MSM, transgender women, and heterosexual men and women. So yung isa naman po is event-driven regimen, on-demand PreP kung tawagin, again, or 2-1-1 regimen. Okay? These are those for those individuals na infrequent naman yung sex or the sexual encounter would be anticipated or planned. Okay, so you give your patients 2 pills, okay, 2 to 24 hours before sex. And then you perform the sexual encounter. And then you take another 1 pill 24 hours after the first 2 pills. And then another 24 hours, you take the 3rd pill. Okay, sorry, the 4th pill na pala. So that's 24 hours after the 3rd pill. But that's actually just your 3rd dose. Kaya siya 2-1-1. Okay. So para kanino po yung event-driven PreP? A man who has sex with another man. Oo. So for MSM lang po ito yung event-driven kasi nandyan po yung ano natin, yung evidence natin. We don't have evidence yet of our on-demand PreP for cis women or transgender women. Okay? For men having vaginal or anal sex with a women or people with chronic hepatitis B infection because we are using our tenofovir. Okay. Okay, so ito po yung evidence for the use of event-driven PreP. And this is based on the Hyper-K trial, which resulted in an 86% reduction in HIV infection among MSM who took the PreP. Okay. So who cannot take the PreP? Those with HIV infection or suspected to be in the window period, those with symptoms of acute retroviral syndrome, those with impaired kidney function because tenofovir can cause nephropathy, those with allergy to any of the two drugs, those who are with chronic hepatitis B, HB sag reactive kasi nga po ginagamit natin yung tenofovir for the treatment of these types of diseases. And for those who are with a weight of less than 35 kilos. Of course, you always discuss this with your patient. When and how compliant should they be when they are started on pre-exposure prophylaxis? Take note of the non-adherence, which is a very common reason why PrePs fail, and the importance of follow up with their doctor to monitor their kidney function, especially if they have been on this pre-exposure prophylaxis regimen for quite some time. So ang common question is, how soon do we achieve protection after we start PreP? So tatanungin tayo ng pasyente, Doc, nag-start na ako ng PreP ngayong araw, kailan ko ako pwedeng makipag-sex na unprotected, for example? And the answer here is after 5 to 7 days for anal intercourse and after 28 days for vaginal intercourse. So medyo magkaiba po yung evidence natin for anal and vaginal intercourse. Okay? So, ito lang yung mga anticipated side effects natin. Nausea, abdominal pain, but this is not too common based from my personal experience among my patients. 1 in 200 may have creatinine elevation, which are typically reversible kapag in-stop yung PreP, yung intake ng tenofovir. And 1% average loss of bone mineral density, which is also reversible. Okay. So the baseline test that we perform prior to starting PreP is baseline HIV test, baseline creatinine, tsaka yung hepatitis B status with the patient. This must be done within 30 days prior to the initiation. And what we monitor, syempre yung HIV test, okay? Every 3 months yung follow-up, we monitor for seroconversion ng kanilang HIV status kasi remember, 2 drugs lang yung binibigay natin for PreP. Kapag positive yung patient, kailangan 3 drugs na or ARV regimen tayo na usual yung ibibigay. Okay? Of course, we always assess for the presence of STI other than HIV and monitor our creatinine every 6 months. Okay, so key messages, PreP is another evidence-based strategy to be included in the HIV preventive care continuum. PreP should be considered for all individuals who are at a higher risk for HIV acquisition. And this includes these individuals. Okay? Significant reduction in the risk of HIV has been shown, especially among those with high adherence to the recommended daily dosing of your pre-exposure prophylaxis. Okay? Yung once daily or event-driven PreP or yung on-demand 211 PreP are or is effective, but this is recommended only for MSM kasi wala pa tayong evidence dun sa ibang population. PreP is generally safe. Identified side effects include renal and GI effects. These are usually mild and resolve with discontinuation of the PreP. Ano po yung ginagamit natin na PreP preparation ngayon? It's M-tricytabine plus tenofovir given 1 tablet once a day. Most studies found no increased risk in sexual behavior and sexually transmitted infection. But STI counseling remains to be a very important part of PreP education. And there are reports of tenofovir and or M-tricytabine drug resistance, and is seen especially among undiagnosed HIV infection who were mistakenly started on PreP. So this highlights the importance of us doing a baseline test for patients na gusto nating simulan ng pre-exposure prophylaxis. So, admittedly, medyo nagbabago rin yung pananaw ng mga tao about pre-exposure prophylaxis. PreP might not be everyone's cup of tea. We are in the middle of a losing battle against HIV, as you know, especially in the Philippines. So, the message here is we have to keep an open open mind and reconsider the evidence on the use of pre-exposure prophylaxis as an additional, I say additional and not the only tool against preventing getting the virus. So thank you very much, and thank you for staying with me